Thyroid gland disorders are very common among patients coming to ENT and general surgery OPD. So today I will explain the methods of examination of thyroid gland, and in the next 10 to 15 minutes I will explain what all things you have to examine, and also there are some named methods of examination of thyroid, and this is very important especially for OSCE stations in our board examinations. Okay, examination. Though there are so many sophisticated investigations available at present, the clinical examination of thyroid is a must and it is superior to all other investigations. Okay, so actually where this thyroid is situated, thyroid gland. So if you palpate starting from the chin, the next thing you come and rest your tip of finger is on the thyroid cartilage, the prominence of thyroid cartilage, otherwise called the Adam's apple. So starting from the chin, you come and palpate on next. After chin, actually the next prominence is thyroid cartilage. The Adam's apple will come there. Anatomically, in between the chin and the thyroid prominence, there is a hyoid bone which is rarely palpated. Okay, so actually the hyoid bone will come here, lesser cornea, and also the greater horn of hyoid bone. So hyoid, then comes the thyroid cartilage, and after that the next one you feel with a different consistency is the cricoid cartilage. Cricoid cartilage. And then if you palpate downwards, you will feel the tracheal rings, and also there comes the suprasternal notch. Actually, in between the thyroid and the cricoid and the tracheal ring, you have the isthmus of thyroid gland, and the gland is here. Okay, so here comes the isthmus, and on both sides there is thyroid gland. So if there is any swellings or abnormal enlargement of the thyroid gland, you can palpate it. Like any other swellings in the body, the examination of thyroid gland also contains 4 methods. One is inspection, then what? Palpation, percussion, and auscultation. Okay. And for examination, the things you need is, one is a stethoscope for auscultation. Then to know whether it is moving with deglutition, ideally you want a glass of water. Okay, so you need a stethoscope. You need a glass of water, a tendon hammer, and you also need a piece of paper. For what, I will tell you. Once a patient is coming to your cubicle for examination, you have to introduce yourself to the patient. That is ideally to make a rapport between the patient, and when there is a very good rapport, so your whole job will be easy. So introduce yourself to the patient, and after getting a very brief history, confirm the patient details. That is, ask the patient name and then explain the procedure to the patient. So introduce yourself to the patient, confirm the patient details, and then explain the procedure to the patient and tell him that I am going to examine your neck for thyroid gland enlargement, if any. It will take around 5 to 10 minutes and it's not a painful procedure. Okay, and get the confidence of the patient. Okay, so introduce yourself and then explain the procedure to the patient. After that, The examination of thyroid is actually, there are from three sides. That is, if this is a face of the patient, you have to examine from front, from the side, and also from behind the patient. So, examination from front, from behind, and also from the side of the patient. Now, in inspection, what are the things to be inspected? So, there comes all these. One is the behavior of the patient. There are the thyroid gland may be either it is hypoactive or it can be hyperactive, isn't it? Normal, hypoactive or hyperactive. If it is hypoactive, what will happen? The patient also will be very hypoactive. Okay, very calm or what hypoactive patient. But if the patient is thyroid toxicosis, if there is overfunctioning of the thyroid gland, the patient will be anxious or agitated, or it will be a fidgety patient. Okay, so all these in a hyperthyroidism. Okay, so that has to be pointed out. And then what in the hands? Look the hands of the patient. If there is dry skin, it is always towards hypothyroidism. Okay. So in the hands, it can be either a dry skin, which is characteristic of hypothyroidism, and on the other side, in hyperthyroidism, there will be an increased sweating of the hands, or there will be thyroid acropathy. What is that? The phalangeal overgrowth. Phalangeal overgrowth seen in case of Graves' disease. And palmar erythema, there is redness of the skin of the thenar and hypothenar. Thenar and hypothenar remnants, redness will be there. Again in hyperthyroidism. And look for tremor. How will you look for the tremor? Ask a patient to stretch the hands in front of them and stand. Look for tremor. If there is very good amount of tremor, you can see that with outstretched hands. If there is minimal amount of tremor, you can inspect it by placing a piece of paper over the outstretched hands. So if there is tremor, you can see the paper moving or trembling in front of you. Okay, so that is how you have to examine the tremor. So increased sweating, thyroid acropathy, palmar erythema and tremor will be seen in hyperthyroidism, whereas the dry skin is characteristic of an hypothyroidism. And in pulse, look for rate and rhythm. Okay, feel the pulse and look for rate and rhythm. The rate is in hypothyroidism, it will be reduced. Okay, so rate reduced in case of hypothyroidism, bradycardia in case of hypothyroidism, and increased rate on the other side, that is hyperthyroidism. And the irregular pulse, especially atrial fibrillation, is more commonly seen with the thyroid toxicosis. Okay, irregular. So the rate is reduced in hypothyroidism and rate increased in hypothyroidism, and irregular rhythm is seen in case of hyperthyroidism. Okay. And in hyperthyroidism, what will happen? You know, there will be sweating, and also there will be loss of outer third of the eyebrow. Okay, so there will be sweating and I draw like this because of hypothyroidism, and the eyebrow, the outer 1/3 will be absent. Outer 1/3 of the eyebrow will be absent. Okay, and that is called Queen Anne sign. Or sign of Hertog. I don't know whether Queen Anne had hypothyroidism or not. That you have to verify So these are the two things you get in the face. Dry skin in case of hypothyroidism, and sweating, and loss of outer 1/3 of the eyebrow in case of hyperthyroidism. And all these are eye signs. So the eye signs, there are so many named eye signs that you have to remember. And what is the pathology in the eyes in case of hyperthyroidism? Remember that in hyperthyroidism or in Graves' disease, there is abnormal deposition of connective tissue in the orbit and also in the extraocular muscles. Connective tissue get deposited in the orbit and also in the extraocular muscles. So what happened? These eyes will be pushed outwards. So that is called what? Exophthalmos. Okay. The eyes will be pushed outwards. That is exophthalmos. So that has to be examined from front, from the side, and also from behind the patient. So exophthalmos has to be examined from front. You can very well see the eyes of the patient. You can very well see that. So normally what is the appearance of the eyes? Normally when you look into the eyes, there will be a cornea, the upper eyelid, and also the lower eyelid. Okay. This side also. This is how your normal eye looks. You cannot see the upper part of the cornea, and it is covered by the upper eyelid, and also it goes just through the limbus of the cornea on the lower eyelid. Lower eyelid is not covering the cornea like this. So it is just going through the limbus, that is through the lower part of your cornea. If it is your cornea, the upper eyelid will go through this and the lower eyelid will be go just through the limbus. So that is normal. So if there is extra deposition of connective tissue in the orbit and also in the extraocular muscles, these eyes will be protruded outward. So what will happen? So there will be this is your cornea, and the upper eyelid and also the lower eyelid will be widened. So there will be widening of the palpebral fissure. So there will be a staring appearance. If my upper eyelid and lower eyelid goes like this, you will feel as if I am staring at you. Okay, there will be widening of this is palpebral fissure. The distance of between the upper eyelid and the lower eyelid, it will be widened. Okay, so you can see the sclera all around the cornea. That happens in case of thyrotoxicosis, or in Graves' disease that happens. So that you have to see from front, you have to see the protrusion of the eyeball from the side, and also you have to go behind. Okay, so in front, what are the signs? Named signs, eye signs you can see. These are the eye signs you have to examine. Dial rumble sign. I already told you, because of the deposition of connective tissue in the orbit and also in the extraocular muscles, there will be bulging of the eyeball, that is called exophthalmos, and this eyeball, upper eyelid and the lower eyelid also will be retracted. So there will be widening of the palpebral fissure, and that is called the dial rumble sign. Okay, so the palpebral fissure widen. Okay, that is called the dial rumble sign. So that you will get a staring look, and also there will be infrequent blinking. Infrequent blinking, and that is called the Stellenbosch sign. Okay, and what is von Graefe sign? This is Lidlag. What is that? When you look at an object and look downwards, this upper eyelid also follows the eyeball. But in a patient of having thyrotoxicosis, this upper eyelid will not follow the movement. So there will be a lagging behind of the upper eyelid, and you can see that on looking downwards, your cornea, lower eyelid, this upper eyelid will not follow. It will not move in the same pace as that of the eyeball. So there will be lagging behind of the upper eyelid, and that is called bone graphy sign. How will you examine that? Fix the head of the patient and ask the patient to look at the tip of your fingers, and keep the tip of your fingers around 30 to 40 centimeters, 30 to 40 centimeters from the patient. Then move it upwards and downwards. First move it upward and then move it downwards. So in normal patient, this upper eyelid will follow that. And if I am having thyrotoxicosis, what will happen? If I am looking upward, it's okay. Moving downwards, this upper eyelid, look at my left eye. This upper eyelid will not move or go in pace with the lower eyelid. So you can see a piece of sclera above the cornea, and that is called the bone graphy sign. Okay, so that is Lidlag. And what is this Gifford sign? Sometimes there will be unilateral exophthalmos. Okay, it's not indicated that it should not have a bilateral exophthalmos always. It can be a unilateral exophthalmos. And if it is a unilateral exophthalmos, unilateral cases, it has to be differentiated from intraorbital space occupying lesions, intraorbital or intraocular masses. So that is differentiated by using this Gifford sign. That is, if I am having exophthalmos of my right eye, I have to differentiate it from a space occupying lesion on the right side. So ask the patient to look downwards and try to invert the upper eyelid. Invert it. The inversion is not possible in case of thyrotoxicosis. Okay. Inversion not possible in case of thyrotoxicosis, and that is called the Gifford sign. Okay. So ask the patient to look downwards and invert the upper eyelid. If it is not possible, it is unilateral thyrotoxicosis, Gifford sign. And Mobius sign, it is absence of convergence of the eyeball. Convergence will not be possible in case of thyrotoxicosis. Convergence. Okay. And also there will be absence of wrinkling of forehead on looking upwards in case of thyrotoxicosis, and that is called Geoffroy sign. Geoffroy. I will write it like here. Geoffroy sign. Absence of wrinkling. Okay. So these are the eye signs, named eye signs. Dalrymple sign, that is widening of the palpebral fissure. Stellbach sign, infrequent blinking. Bone graphy sign, that is Lidlag. Then Gifford sign, absence of eversion of the upper eyelid in case of unilateral thyrotoxicosis. Exophthalmos. Mobius sign is absence of convergence of the eyeball, and absence of wrinkling on looking upward is called the Geoffroy sign. All these you examine from front of the patient. You have to examine from side of the patient. This is from front, then from side of the patient. Normally your eyes will be here only. You will not see the pushing forward of the eyes when you look from sides. In case of exophthalmos, these eyes will be prominent. It will be bulged out. Okay. When you see from side, this bulging you can very well visualize, and also from behind. The patient is seated in front of you. You stand behind the patient and look. In the meantime, you instruct the patient to slightly look upwards or slightly raise the head. You are standing behind, patient seated in front of you with slightly raising the head. You are looking from above. So that method is called Navsiger's method of examination from behind. Okay. Navsiger's method. Don't worry with the so many names. This is very simple method. What I have already told is Navsiger's method. Stand behind the patient and look into the from above and ask the patient just to look upwards. Just raise the head. Okay, that is Navsiger's method. What will you see normally? Normally, if you are looking from above, head of the patient and you are looking from above, this is supraorbital ring. If this is your, you can see the nose, tip of nose also here. So if you are looking from above, normally this supraorbital ring. This eyes will not project beyond the supraorbital rim. But if there is proptosis, you can see eyes projecting like this. You can see the eyes projecting beyond the supraorbital rim. Okay, so if so, it is called the positive Navsiger's sign. Okay, Navsiger's sign. Positive. So Navsiger's method from examination from behind, and if you see the orbit projecting beyond the supraorbital margin or supraorbital rim, it is exophthalmos with the Navsiger's sign positive. Okay, so this is regarding the eye findings in case of thyroid toxicosis. And along with that, look for eye movements also. That is a classical edge test. What is that? Edge test. First, fix the patient's head. Ask the patient to follow your tip of your fingers. Then you, starting from the center, move to left side, then above and then below. So then go to the other side, above and below. That is edge test. Okay. So ask the patient to look at the tip of your fingers. Move it to the left, above, below, then to the right, above and below. And look for any restriction of eye movement, and also ask the patient to tell if there is pain or movement, and also double vision. Okay, that is edge test. Pain and diplopia or double vision, and restriction of eye movement. Eye movement restriction. Okay, so then come to thyroid gland, inspection of thyroid gland. In the thyroid, see the patient in front of you and look for the skin over the neck. Look for presence of any erythema or any dilated veins. Okay. Erythema present, then edema or any dilated veins over the skin of the neck. The next thing you have to examine is whether any scar in the neck, looking for any previous thyroidectomy, okay, or any other surgeries in the neck, that is scar. And then you have to examine the any masses in the neck. It can be either a lymph node, or it can be a thyroid swelling, or it can be a thyroglosal cyst, etc. So look for any masses. There comes the importance of drinking water, or ask the patient to swallow, because this thyroid gland is covered in the pretracheal fascia, so it will move with deglutition. Okay. Moving with the deglutition. And the normal thyroid gland will not be visible on inspection. Okay, normal thyroid gland is not visible in inspection. So if the mass is there, look for whether it is moving with deglutition, and also ask the patient to protrude the tongue. And if the mass is moving on protruding the tongue, if it is moving upward, it can be either it is not thyroid. If it is moving with the protrusion of the tongue, it is thyroglossal cyst. Okay. If it is not moving with deglutition, it can be either a thyroid or it can be a lymph node. Thyroid and the lymph nodes will not move with the protrusion of the tongue, and thyroid will move with deglutition but will not move with protrusion of the tongue. So this inspect for this. And if the patient is having a very short neck and also very fatty patient, the inspection of the thyroid mass will be difficult. In that case, you can do inspection by asking the patient to hyperextend or extend the neck and pushing the head backwards. Ask the patient to keep the hands of the patient like this and just extend and push the head backward so that this mass will be visible properly, and that is called the Pissillo's method. Of inspection. Okay, that is, ask the patient to hyperextend and push the head backwards against this. Okay, this is Pissillo's method. So the mass will be more prominent, and look for the skin surface for any dilated veins or erythema or edema, and then any scar tissue present. And if it is a thyroid gland swelling, it will move with deglutition, but it will not move on protrusion of the tongue. So Pissillo's method of inspection of the thyroid gland. Then next is we have to palpate. This palpation, there are two methods: standing from behind and standing in front. So it can be an anterior approach, that is standing from front of the patient, and standing from behind the patient and examining, that is posterior approach. Okay, so first if this is the your thyroid gland, trachea, cricoid cartilage, and thyroid cartilage. Okay. So you are looking from examining from front of the patient, and you can palpate while asking the patient to swallow, so that if it is moving with deglutition, you can confirm that, and also you can look for the lower border of the swelling. If there is a very big swelling, you can palpate the lower border. On moving with deglutition, you can just palpate the lower border of the swelling, and you can look for if there is any retrosternal extension or not. If there is retrosternal extension, you will not be able to palpate the lower border of the thyroid swelling. Okay. There are two named methods in anterior approach. That is, one is Lahey's method and another one is Kreil's method. Kreil's method. So Lahey's method is mainly for the posteromedial surface. Posteromedial surface, inner side. Okay. Posteromedial surface. There is a swelling. The patient sitting. I am standing in front of the patient, and I am going to examine the left lobe of posteromedial surface of the patient. So, keeping my left thumb, I am pushing the thyroid towards the left side. Okay, I am pushing it towards the left side. So, here it will come like this. So, it will be prominent on the left surface, pushing it towards the left side, and with my right fingers I'll examine the posteromedial surface. Okay, it will be pushed like this, and this side I'll examine. Okay, so that is Lahey's method. Posteromedial surface, pushing towards the side to be examined with my left thumb, and I am examining on that side, right? And Kreil's method is mainly for small nodules. For that I am using my right thumb and examining the small nodules like this. Okay, I am examining. So that is Kreil's method. Both Lahey and Kreil are from anterior approach, and posterior approach, standing behind the patient and ask the patient to slightly hyperextend the neck and examine. And from standing behind the patient, ask the patient to slightly hyperextend and then examine with your fingers, right? And always use the pulp of your fingers and not the tip of your fingers. Always use the pulp of your fingers for examining, right? And after that, palpate the trachea and also palpate for carotid pulsations and look for any other lymph nodes. So after palpating the thyroid for any masses, look for lymph nodes, carotid pulsation, and also palpation of the trachea, whether it is midline or it is displaced to one or the other side. Trachea, we have to do Cocker's test. Cocker's test, what is that? That is for a scabal trachea, deviated trachea, and the swelling is too big. It is pressing on the trachea. So you have to look for that. That is, ask the patient to sit and take deep breath. Along with that, you push on both lobe of thyroid. If the patient develops stridor, that means that the patient is having a scabal trachea or a deviated trachea, and that test is called Cocker's test. Got it? Ask the patient to take deep breath, and along with that, you press on both lobe of thyroid gland. If the patient develops stridor, it is Cocker's test positive. It shows that the patient is having a scabal trachea, that is, the thyroid mass is pushing on the trachea. Okay, so that also has to be done along with the examination of trachea. Scabal trachea. Okay. In palpation, actually, of the anterior and posterior approach, the posterior approach is considered to be better than the anterior approach. Especially, you will be asked that in examination. So, posterior approach or examining the thyroid from standing behind the patient is considered to be better than an anterior approach. Next is percussion. If you get a retrosternal dullness, that means there is retrosternal extension. Okay. Retrosternal. And also one thing, while examining from the neck up to the upper part of this sternum, the dressings should be removed. Okay, that area should be clear, and then only you can percuss from here, from the thyroid gland up to the retrosternal area, up to the upper part of sternum. You have to percuss, and if any retrosternal dullness, that means there is a retrosternal extension of the thyroid gland. Okay, then auscultation. Look for any bruit. Keep your stethoscope over this and look for any bruit or increased vascularity is seen in case of thyroid toxicosis. Okay. So that is inspection, palpation, percussion and auscultation of the thyroid of all these parts. And there are also some special tests for thyroid gland examination. One is reflexes. I already told need of a tendon hammer. With that, look for reflexes. And if there is hyporeflexia, sluggishness of the reflexes seen in case of hypothyroidism. Okay. And proximal myopathy. How will you do that? Proximal myopathy is seen in hyperthyroidism. Okay, hyper. That is, ask the patient to stand from the sitting position with arms crossed. If the patient cannot do that, that means the patient is having a proximal myopathy, which is pointing towards an hyperthyroidism, and also look for pretibial myxedema. Okay, and to complete this, the other investigation needed are thyroid function test, free T4 and also ultrasound examination. So these are the methods of examination of thyroid gland. There is a checklist also that is very important for OSCE examination, and I will put the checklist in the description box. Okay, thank you.